Uh, Good morning. Hello, Billy, am I audible?
Yeah, you are.
Yes,
Okay.
sir.
So I welcome the new batch of DNB students to this group. So we are planning to have a basic sciences seminar, which will be done by first year resident. And today we are starting with the first chapter of the basic principle, metabolic and endocrine response to injury. These will be delivered by first year resident who are joined in different places. Aditi, Sritama and Ruplekha. So we'll study the program, and today Professor P.K. Bhattacharjee, Professor of Surgery, RGK Medical, will moderate the session. I request Aditi to start your presentation. Share your screen and start.
Good morning, sir. Hello. Hello.
Good morning. Continue.
Hello. Good morning, sir. My topic is mediators of metabolic response to injury.
Please continue.
Response to injury. Now, whenever an injury occurs, the response is graded. More severe the injury, greater is the response. Following a minor injury or an elective surgery, there is a transient and modest rise in temperature, heart rate, respiratory rate, energy expenditure, and the peripheral WBC count. But following a major trauma or sepsis, rise are accentuated, and it leads to SIRS, systemic inflammatory response syndrome, hypermetabolism and catabolism, shock, MODS, that is multiple organ dysfunction syndrome. Immunological sequelae may also evolve from pro-inflammatory state driven by the innate immune system into a compensatory anti-inflammatory response. Here we can see the resting metabolism state during a minor trauma, this curve, and during major trauma or major burn injury, the metabolic state rises. The nitrogen excretion also increase during infection, severe sepsis, skeletal trauma, and major burn. Mediators of injury. There are two mediators by the immune system and by the neuroendocrine system. Immune system acts via inflammatory reflex arc involving the innate and adaptive immune system, and neuroendocrine system acts via hypothalamus pituitary and adrenaline axis. Now, there is a Metzinger's danger hypothesis which states that immune system activation and propagation depends more on cellular damage signals than on the presence of foreign substances. And that is why body does not mount any immune response to the developing fetus or the cancer cells. This is communicated via DAMP called alarmins, that is danger associated molecular proteins. In case of pathogens, these are called pathogen associated molecular patterns. Now, these DAMP is recognized by pattern recognition receptors. And one of the most important PRR is TLR family, that is toll-like receptor. TLR126 recognizes bacterial lipoproteins. TLR3 recognizes double-stranded RNA of virus. TLR4 lipopolysaccharide of bacteria. TLR5 recognizes bacterial flagella. TLR7 and 8 single-stranded RNA of the virus, and the TLR9 recognizes bacterial DNA. Here we can see the pathogen-associated molecular protein, which is recognized by toll-like receptor. TLR is the extracellular pattern recognition receptor, and NLR is nucleotide and nod-like receptor, which is an endogenous intracellular pattern recognition receptor. This PAMP triggers the multiple cellular pathways via these TLR and NLR, producing pro-inflammatory and anti-inflammatory cytokines and leading to inflammatory response. Now, the immune system starts with innate immunity, and this is the first line of cellular defense. Neutrophils are the first cells to arrive at an injury site. The neutrophils release the pro-inflammatory granules. Azurophilic granules, those are the primary granules, specific or secondary granules, and tertiary gelatinase granules. Neutrophils also release a fiber meshwork called neutrophilic extracellular trap, to which proteins and histone gets adhered and trap the bacteria or foreign pathogens. Neutrophils also leads to angiogenesis via vascular endothelial growth factors, and neutrophils shows plasticity by the anti-inflammatory subsets. Macrophage are the second cell which has pattern recognition receptors. Initially, monocytes in the bloodstream are travels to injury site and gets converted into the macrophage, and there they release pro-inflammatory mediators like interleukin-1, TNF-alpha. These are the antigen-presenting cells, and it shows plasticity and phenotypic variation. Macrophage, in phenotypic variation, there is macrophage 1, type 1, that releases the pro-inflammatory cytokines, and this stimulates the helper T cells, and macrophage 2 releases anti-inflammatory markers. Dendritic cells are the major antigen presenting cells. They stimulate T cell activity. It occurs via co-stimulation, CD80 and 86 on dendritic cells and CD28 on T cells. They also process self-antigens and present it to the regulatory T cells. This is important for the tolerance and immune homeostasis. Here we can see the different cells involved in the innate immune system, the endothelium layer, the basement membrane, which creates the physical barrier, macrophage, which eliminates microbes and these are the sources of immune mediators. Polymorphonuclear leukocytes, that is neutrophils, they eliminate the dead tissues and pathogens. B cells release antibodies, and then they antibodies and cytokines, and B cells also becomes the memory B cell. Helper T cells activates and regulates the immune response. And there are other cells also like mast cells, complement system is there, and clotting factors, and cytotoxic T cells and helper T cells. Adaptive immune system, which is of two types, humoral mediated immune system and the cell mediated immune system. The CMI involves the T cell activation, which occurs via the T cell receptors. The antigen is presented via antigen presenting cells, mostly by dendritic cells and also by macrophage. This antigen and MHC complex, here we can see this antigen and extracellular proteins is processed in the lysosome of the dendritic cells, and this is attached to the MHC2 complex. This antigen is presented to the T cell receptors. This converts the naive T cells in spleen and lymph node into CD4 T cells and CD8 T cells. There is further differentiation of the CD4 T cells. This occurs in presence of interleukin-12. CD4 T cell gets converted to Th1 cell, which release interferon gamma and clear the intracellular pathogens. In presence of interleukin-4, it gets converted to type 2 helper T cell and release interleukin-4, 5, 13 and clear the extracellular pathogens. In presence of interleukin-6 and TGF tumor growth factor beta, it really gets differentiated into Th17 cell, release interleukin-17 and clear extracellular pathogen and fungus. CD8 T cells release interferon gamma and targets the viral infected cells. In B cell activation, there is antigen recognition by the B cell receptors that gets activated to the B lymphocytes, proliferate and differentiate and then there is production of antibody secreting plasma cells. There is that produce IgM antibody, IgG, and there is isotype switching, which leads to IgG, IgA, and IgE production. And then there is affinity maturation, which leads to high affinity of immunoglobulin, which has high affinity for the antigen. Lastly, there is memory B cell, which helps in for next infection. The intracellular protein is processed in the cytoplasm of the dendritic cell by the proteasomes, and this is attached to MHC1. Extracellular is processed in lysosome attached to MHC2 and presented to the CD4 T cells. Inflammatory reflex arc. The DAMP and PAMP are recognized by the peripheral, produce peripheral signals and recognized by the afferent sensory neurons, nociceptive neurons. These neurons also has TLR and IL-1 receptor and TN-alpha receptor. Through spinal cord, it reaches the brainstem in dorsal vagal complex made of nucleus tectus solitarius, dorsal motor nucleus of vagus, and the area postrema. Traveling through thalamus, hypothalamus, and pituitary, efferent motor vagus neurons release acetylcholine esterase, and these finally leads to decrease in pro-inflammatory cytokines, reducing the pro-inflammatory cytokines. Neuroendocrine system. Pro-inflammatory cytokines like interleukin 1, 6, and 8, TNF-alpha, these are the cytokines produced within 24 hours of the injury, and they act directly on the hypothalamus to activate the hypothalamus pituitary adrenaline axis. Hypothalamus releases cortisol releasing hormone from the paraventricular nucleus. This acts on pituitary for ACTH release. ACTH in turn causes cortisol release from the adrenal gland. Negative feedback by cortisol decrease TRH and ACTH release, as well as the pro-inflammatory cytokines release. Cortisol binds to the glucocorticoid receptor heat shock protein complex and replaces the heat shock protein, making a complex of cortisol and glucocorticoid receptor. This glucocorticoid receptor. This cortisol glucocorticoid receptor complex acts on the nucleus to produce anti-inflammatory actions, which leads to decrease in interleukin 1, 6, TNF-alpha, chemokines decrease, adhesion molecules decrease, pro-inflammatory receptors, inflammatory enzymes, these are decreased, and it also inhibits the NF-κ-beta transcription. It leads to apoptosis of the basophil, eosinophil, neutrophil, Th1 and Th2 lymphocytes. Cytokine profile is altered in macrophage from pro-inflammatory to anti-inflammatory state. So overall, cortisol glucocorticoid receptor reduces the inflammatory response. Now, acute level of high level of glucocorticoid exposure, as in infection, ischemia, trauma, which can enhance the peripheral immune system. Neuroendocrine response to the injury is biphasic. In acute phase, there is active secretion of pituitary hormones like growth hormone and prolactin, and counter-regulatory hormones are increased, like cortisol, glucagon, and adrenaline increases. Growth hormone has the direct lipolytic action, insulin antagonizing, and pro-inflammatory properties. In the chronic phase, hypothalamus suppression occurs, and the respective hormones from hypothalamus targeting, their serum level decreases. The innate immune system interacts in a very complex manner with the adaptive immune system, and it leads to generation of metabolic response to injury. Here we can see innate immune system interacting with adaptive immune system. There is rise in interleukin 1, 6, 8, TNF-alpha, and this acts via hypothalamus, leading to pyrexia. Acute phase reactants in the liver increases. Skeletal muscle protein degradation, adipocytes lipolysis occurs, hepatic gluconeogenesis, and hypermetabolism. There is rise in ACTH and growth hormone, adrenaline and cortisol increases in adrenaline. Within hours of upregulation of pro-inflammatory cytokines, endogenous cytokines and antagonist enters the circulation and control the pro-inflammatory response, mitigating the inflammation. There is CARS that results. The CARS, that is compensatory anti-inflammatory response syndrome, results in immunosuppression and increased susceptibility to the opportunistic infection. There is a paradigm called SIRS-CARS, which states that after a large systemic insult, there is the early death occurs due to the systemic inflammatory response syndrome, and the late death occurs due to compensatory anti-inflammatory response syndrome, which drives the immunosuppressed state. If the patient survives the late stage, he may enter into a state of chronic critical illness called PICS, persistent inflammation, immunosuppression, and catabolism syndrome. There are local mediators called specialized pro-resolving mediators, which are essential fatty acid derived lipoxin, resolving, protectin, and mycins, which influence the return to the homeostasis after an inflammatory response.
Okay, it was a nice presentation.
We can have 5-minute discussion.
Yes, sir.
Hello.
Hello.
Yes,
sir.
It was a nice presentation, but I would have liked a few more, basic discussion on some basic issues, like how hypovolemia is a part of this trauma and acute inflammation, how the body responds to hypovolemia, what are the changes which takes place at the level of the blood vessels or endothelium after an injury, be it surgery or any other trauma, and hypercoagulability, which is one of the sequelae of acute inflammatory response. What are the causes of that? And those should have been included. A few things should have made it a bit more interesting. But otherwise, overall, it was a very nice and informative presentation.
Okay.
Actually, the all systems in the body responds to the stress, and this stress response depends on the degree of injury and the body's different mechanism came into action. So all the system has changes, and as Dr. Bhattacharya just pointed out, one, there is a hypovolemia. Body tries to compensate to restore volume, and as a consequence, different systems are activated. Okay, so it's a very extensive chapter. I agree that every system, every metabolism got altered in injury. So our next presentation will be on a continuation of this. Whenever there is a trauma or stress, body responds, and in this response, there are two main changes. And Cuthbertson in 1942 has proposed this model of ebb and flow. Ebb means immediate response, and flow means how the body keeps on going with this stress response. So I request the next presenter to start the presentation. Ebb and flow model for this response to injury.
Sir, just a minute. I'm trying to share the screen. Okay.
Doctor, there's a screen there's an option at the bottom of
Yeah,
your screen.
sir. Yeah, I saw the option. When I'm selecting, they're like not letting me like share it. I don't know. Um,
Try
just a
again.
minute. Yeah. I got it. Yeah. Okay. So is it visible?
Yeah, it is.
Okay. So good morning. I am Dr. Sridhama from Ruby General Hospital. Um, I'll start with the ebb and flow model of the metabolic responses to surgery and trauma. Um,
But
so
your
the
screen appears
background.
to your screen
Sorry,
appears
sir.
to your
The
screen
screen
appears
is
to be
blank.
blank.
It's blank.
Yeah,
Okay,
it's a
next slide.
white
Next,
screen.
next one.
No, that is also
Uh,
blank.
okay. Sir, window. Sir, okay, I'm trying again.
Now it's all right. Now it's all right. Hmm.
Okay, sir.
Can you just change the slides once, doctor, so we can check whether it's working or not? Can you go to the next slide?
Yes, sir.
Yeah,
Yeah,
it's visible now. Thank you.
Okay,
it's all
sir.
right. Yes, please carry
Okay,
on.
so yeah, so I'll start with the ebb and flow model of the metabolic responses to surgery and trauma. So the background of this is that it starts from the response to injury, mediators of injury, and we have to know that injury is always graded, and the response is directly related to the severity of the injury, and the concept is applicable to a metabolic as well as physiological and immunological changes. And after an elective surgery, which is basically of moderate severity, there is a transient physiological response of the body, like rise in temperature, pulse rate, respiratory rate, energy expenditure, and increased WBC counts. In cases of major trauma or major surgery, the changes are accentuated, and that may develop into a picture of SIRS, or also known as systemic inflammatory response syndrome, hypermetabolism, catabolism, shock, as well as MODS, or multi-organ dysfunction syndrome. So the metabolic changes, they transform with time. Like as we eventually start from hours to days and weeks, the changes also change. So particularly the immunological sequelae of a major injury evolves from a pro-inflammatory state driven by in the innate immune system, which consists of macrophages, neutrophils, dendritic cells, into a compensatory anti-inflammatory response syndrome, or CARS, which suppresses the immunity, and that results in lower resistance to infection. The metabolic response to injury in human beings have been described by Sir David Cuthbertson in the year of 1930 into the ebb and the flow model. So here it divides injury responses to injury into two phases, mainly the ebb phase and the flow phase, and after that there is a recovery phase. Basically, the ebb phase lasts for 24 to 48 hours, and the flow phase basically stretches from days to weeks. And the flow phase has two main divisions. First is catabolism, and then it moves into anabolism. So I'll discuss that in a few slides. The ebb phase is following 24 to 48 hours of injury. It is characterized by hypovolemia, decreased metabolic rate, reduced cardiac output, hypothermia, and lactic acidosis. The predominant hormones which act during the ebb phase are catecholamines, cortisol, and aldosterone. This phase deals with preservation of the circulating volume and energy stores for the purpose of recovery and repair. The flow phase follows the ebb phase, and the features corresponds to SIRS. In this phase, there is mobilization of the body energy stores for recovery and repair. Subsequently, there is replacement of lost and damaged tissue, and this is divided into an initial catabolic phase and an anabolic phase. So what happens during the F phase is, as we have described, uh, it is the first initial phase, and there is basically decrease in volume, decrease in BMR, decrease in cardiac output, decrease in temperature, and there is a lactic acidosis. So during this phase, we basically we aim to conserve the circulating volume and the energy stores. And after this, the body moves into a hypermetabolic phase. And during hypermetabolic phase, there is more mobilization of energy stores, which is why the body has loss of muscle. The body has muscle wasting as well as nitrogen losses, and it corresponds to SIRS. So the characteristic of the catabolic phase, it is basically lasting for 3 to 10 days. There is raised production of counter-regulatory hormones, that is catecholamines, cortisol, insulin, glucagon, and inflammatory cytokines, which mainly consists of IL-1, IL-6, and the TNF-alpha. There is significant fat and protein mobilization, and there is increased in urinary nitrogen excretion. After this, the anabolic phase follows, and that lasts for days to weeks. Following the catabolic phase, positive nitrogen balance occurs in this phase. Basically, in this phase, the body transitions from the catabolic phase to slowly anabolic, that is building up mechanism, and then it comes back to recovery. And here there is replacement of lost resources of the body or lost volume. So there are some key catabolic elements in this flow phase. The first one is hypermetabolism. Hypermetabolism basically occurs due to an interaction between the central metabolic control and there is also peripheral energy utilization. So here what happens is first there is energy expenditure, and which is increased by central thermodysregulation. There is central thermodysregulation occurs due to the inflammatory cascade. Basically, during inflammation, there is the hypothalamus increases the temperature of the body, and thus there is central thermodysregulation. There is increased sympathetic activity, and there is abnormalities in wound circulation, which is basically caused by increased lactate synthesis and in the ischemic areas of the wounds. And though this lactate is again metabolized by the Cori cycle in hepatic metabolism. Then there is increased protein turnover of the body, and there is also nutritional support, and all these factors lead to energy expenditure. And the hypermetabolism phase at this moment in modern clinical practice is limited due to a few routine critical care that we do in hospitals, and that includes bed rest, ventilation, and also immobilization. And sometimes we also like have extensive temperature regulation from outside. The second part is after hypermetabolism is alteration in the skeletal muscle protein metabolism, basically muscle wasting. So major site of protein loss in the body is skeletal muscle, although respiratory muscles and the enteric muscles or the gut muscles are also affected with nitrogen loss. Under extreme, sorry.
Continue.
Please carry on.
Under extreme catabolism, urinary nitrogen loss can exceed 14 to 20 grams per day, and which is equivalent to 500 gram of skeletal muscle loss. This occurs as a result of muscle protein degradation coupled with decreased muscle protein synthesis. This is mediated at the molecular level by activation of the ubiquitin proteasome pathway. The patients experience increased fatigue, reduced functional ability, decreased quality of life, increased risk of morbidity and mortality during this phase. And it can also result in immobility and contribute to hypostatic pneumonia and death if prolonged and if the phase is excessive in length. The major site of protein loss is skeletal muscle, as we have discussed, but there is also respiratory muscle and enteric muscle loss, which can lead to hypoventilation in respiratory muscles, as well as cause respiratory infections like pneumonia. Also, like hospital-acquired pneumonia is an important reason following surgery. Then there are gut muscle involvement can lead to paralytic ileus and uh, decreased bowel movements. And after that, patients experience increased fatigue due to more protein loss and decreased functional ability and decreased quality of life. Then there is alteration in hepatic protein metabolism. Uh, Liver has a protein turnover rate of 10 to 20% per day. Sorry, sir. Actually, I couldn't find a quieter place. I was on rounds at last night. I only found the canteen to for the internet to work. Uh, so the liver has a protein turnover rate of 10 to 20% per day. There is a major export protein of liver, which is albumin, which has a turnover rate of 10%. The transcapillary escape rate of albumin is 10 times the rate of its synthesis, and during sepsis or injury or major trauma, this may increase 3 times of the normal rate. So cytokines, IL-6 in particular, promote hepatic synthesis of positive acute phase proteins, and also negative acute phase reactants decrease during this phase. So to summarize, the liver has a protein turnover rate which is more than the skeletal muscles, and there are many export proteins of liver, but albumin is major and it has a turnover rate of about 10%. Transcapillary escape rate of albumin is 10 times. Basically, albumin concentration is increased. Albumin concentration is decreased due to increased vascular permeability, which occurs during this phase of metabolism, that is the flow phase, and uh, cytokine response basically occurs due to in inflammatory conditions, and there is circulation of polymorphonuclear cells which increase a range of cytokines like IL-1, IL-6 and TNF-alpha, but IL-6 in particular promotes hepatic synthesis of positive acute phase proteins. Acute phase protein response basically is also called as a double-edged sword, which is important for recovery of the body, but the synthesis only occurs at the expense of valuable muscle tissue, and that is why it also like affects metabolism of the body. That is, it causes hypermetabolism for the synthesis of positive acute phase proteins. Negative acute phase proteins, on the other hand, they basically are decreased due to the increased TER or the transcapillary escape rate, and that is why the hepatic synthesis is not compensatory for the negative acute phase protein decrease. Then the major next important factor is insulin resistance. Insulin resistance occurs post-operatively, and it basically mimics type 2 diabetes mellitus. This hyperglycemia develops as a result of increased glucose production combined with decreased glucose uptake in peripheral tissues, and basically as it does in type 2 diabetes mellitus. The suggested mechanisms of this resistance include the action of pro-inflammatory cytokines and the decreased responsiveness of insulin-regulated glucose transporter proteins. Insulin resistance following stress response or trauma on surgery. The degree of insulin resistance is proportional to the magnitude of injury process, and following routine abdominal surgery, insulin resistance may persist for about 2 weeks. Sometimes we compensate this insulin resistance by constant insulin infusion in critical care to compensate the resistance or to keep the blood glucose level in normal limits. And sometimes the risk of this aggressive treatment can also lead to hypoglycemic shock. And so we can summarize this ebb phase and the flow phase at last. The ebb phase has a duration of 24 to 48 hours, and the flow phase has been divided into catabolic phase, which lasts for 3 to 10 days, and the anabolic phase, which lasts for weeks. The characteristic of the ebb phase basically resembles shock, and here there is an increase in volume, increase in BMR, decrease in volume, decrease in BMR, decrease in cardiac output, decrease in temperature, and lactic acidosis. On the other hand, the flow phase resembles SIRS. So there is a tissue edema, there is increased vessel metabolic rate resulting in hypermetabolism, there is increased cardiac output, there is increased temperature, there is leukocytosis, there is increased oxygen consumption and increased gluconeogenesis. The hormonal regulations consist of catecholamine, cortisol, and aldosterone during the ebb phase, and during the flow phase, catecholamines, cortisol are also complemented with insulin and glucagon. The main role in ebb phase is to conserve the circulating volume and energy stores for recovery and repair, and in flow phase, there is mobilization of body energy stores for recovery and repair. That is all for my slide.
You're finished?
Yes, sir. It's
Okay.
and
You can temporarily
Okay.
mute your
Thank
mic
you.
and it will be a bit quieter, the environment. Hello, can you hear us?
yes, sir. Yes, sir.
Okay, okay. Your presentation is also quite nice, but again, from the we would have liked to have a more clinical inclination towards these responses. Like for example, what I mean to say is like following trauma, there is increased metabolic demand, as you said, and there is a reduced intake and overall and increased demand for NHC, and that is the reason why sequentially this the catabolism is basically is in response to the increased metabolic demand. So sequentially the body stores of carbohydrate, then fat, and then protein is utilized. So you should mention that likewise, like for example, the glycogen storage in the liver is the first thing that is utilized with the help of the catecholamines and glucagon. The glycogen is broken up into glucose, that is called glycogenolysis. Then the non-carbohydrate substrates like the lactate, as you mentioned properly, is then utilized. Lactate, amino acids, and the product of the fat metabolism like glycerol, they are utilized for again synthesis of glucose, that is called gluconeogenesis. You mentioned well about the insulin resistance and reduced insulin secretion. The fat is broken up, the triglyceride stores in the body is broken up into free fatty acids. Okay, the free fatty acids are utilized for the energy expenditure once the glycogen stores have been, what do you call it, somewhat glycogen storage of the liver has somewhat been utilized. Then the fat starts getting the subcutaneous fat it starts getting degraded into free fatty acids and glycerol. The free fatty acids are again utilized for the formation of the ATP in the body. Okay, glycerol is a substrate of this gluconeogenesis, and it is important to remember that brain is can utilize only glucose. Now, once the glucose has been, the glycogen storage has been utilized from the liver, the brain needs other sources of energy. So here comes the role of the free fatty acids, which are converted in the liver to ketone bodies. Now, ketone bodies can again be utilized in the by the brain for energy as energy resource. And finally, once the fat sources have also been utilized, then the body protein skeletal muscle starts getting broken up to release the amino acid, which is again utilized converted to glucose, especially the what we call the glucogenic amino acids are broken up into converted into glucose. That is called gluconeogenesis. Okay, so this sequence of events, like initially the carbohydrate storage in the liver, then the fat storage, then the protein stores, how they are utilized sequentially, that is important from a clinical point of view.
Yeah, okay, okay, sir. Thank you, sir.
You have nicely summarized the ebb and flow phase. And in a flow phase, although the catabolic phase lasts for 3 to 10 days, but in some situations where the injury or the sepsis is continuing, this flow phase, the catabolic phase may be prolonged. Basically, it's usually between 3 to 10 days, but may be prolonged because of the underlying injury. And in the flow phase, in the anabolic phase, a phase where the body tries to recover from the stress or the insult. It's a nice summarization. So we can pass into the next presentation. Dr. Srilekha, please share your screen and start presenting.
Good morning to all my respected sir and my beloved juniors and seniors. Sorry, Rasmus. I would like to describe today the ERAS protocol. Please give some minutes. I will try to share my screen. Sorry, sir, but I can't.
You have sent me slides to Milin earlier.
Yes, yes. I sent it.
I'll share the screens.
Yeah.
Good morning, sir. I am going to describe about the ERAS protocol today. ERAS protocol. ERAS, that is enhanced recovery after the surgery. If we describe about what is ERAS, then we are going to describe the compared with the traditional perioperative care, the enhanced recovery after the surgery program represent a fundamental shift in the process of care that includes multiple interventions and attenuate the surgical stress, maintain a physiological function, and expedite the return to the baseline. While each intervention has a small effect, but together they have a stronger synergistic effect. Now I am going to discuss about the components of the ERAS.
If we describe it as a pre-operative phase, intraoperative phase, and post-operative phase, in pre-operative phase, we can do the pre-admission counseling, fluid and carbohydrate load, no prolonged fast, no or selective bowel preparation, antibiotic prophylaxis, thromboprophylaxis, no pre-medications. In intraoperative phase, I can give the short-acting anesthetic agent, mid-thoracic epidural analgesia, no drains, and avoidance of salt and water overload. Whereas in post-operative phase, I am going to use the no nasogastric, not still use the nasogastric tube, prevention of nausea and vomiting, avoidance of salt and water overload again, early removal of the catheter, early oral nutrition, non-opioid oral analgesia, early mobilization, simulation of gut motility, audit of compliance and outcomes. So now I am going to discuss these components in our major surgeries, like I am choosing that elective colorectal surgery. Guidelines for perioperative care in elective colorectal surgery. First of all, pre-admission information, education, and counseling. If we do the proper and complete information to the patient, it can reduce the surgical and anesthesia-related anxiety and the subsequent pain. Next of all, smoking. We should advise to keep the smoking pre-operatively at least 4 weeks to reduce the respiratory and wound healing related complications. Then I come to the malnutrition. If the patients at high risk of malnutrition, they should receive the nutrition at least 7 to 10 days, preferably using the oral route. Anemia is the most common presentation in the colorectal surgery. The patient usually give intravenous iron because it has a low risk of adverse reaction and more effective compared to the oral iron in restoring the hemoglobin concentration. It is in both cases of iron deficiency anemia and also in the anemia of the chronic diseases. And compared to the blood transfusion have many long-term side effects, so we can avoid it and we can give the intravenous iron preparation. Now come to the vomiting part. If the patients have 1, 2, or 2 risk factors regarding the vomiting, we can do the 2-drug combination using the first-line antiemetic. And if the patient has greater than 2 risk factors, we can give them the 2 to 3 first-line antiemetic. But if nausea vomiting still occurs despite the prophylactic treatment, we can use the salvage therapy provided using multimodal approach, that is using different classes of drugs. Now come to the antibiotic prophylaxis, sir. Antibiotic prophylaxis, intravenous antibiotic prophylaxis, single dose should be given 60 minutes before the incision. Patients receiving the oral mechanical bowel preparation should receive oral antibiotics. And the regarding skin disinfections, we should be performed by using chlorhexidine alcohol-based preparation. Now come to the mechanical bowel preparation. It is a major component also in the colorectal surgery. The combination of the, it is a cohort study. Cohort study shows that the combination of the oral antibiotic preparation together with systemic antibiotic preparations and the mechanical bowel preparation have reduces the morbidity much better compared to the colorectal surgery, compared to the systemic antibiotic plus mechanical bowel preparation or systemic antibiotic use of systemic antibiotic alone without any mechanical bowel preparation. Regarding the fasting before the surgery, it is guided that patient can eat until 6 hours and can take clear liquids until 2 hours before the initiation of the anesthesia. Perioperative fluid therapy. In perioperative fluid therapy, the goal is to avoid the excessive fluid therapy or to prevent the organ hypofiltration. Excessive fluid therapy, which can causes the weight gain more than 2.5 kg, should be avoided, and the perioperative near zero fluid balance approach should be preferred in case of perioperative fluid therapy. And now we go to the minimally invasive approach, that is laparoscopic surgery or microsurgery. In this case, the advantage for more improved and rapid recovery, reduce general anesthesia and general complications, reduce wound-related complications, including like incisional hernia, like your adhesion. It is also enabler for successful administration of many or major components of the gas, like we can give the opiate sparing analgesia and optimize sleep therapy. Now come to the drains. Pelvic and peritoneal drains show no effect on clinical outcome and could not be used routinely. Otherwise, it is much needed. Nasogastric tubes, perioperative nasogastric tubes is inserted during surgery. Could be anesthesia. Analgesia, as mentioned before, we should avoid the opioids and apply multimodal analgesia in combination with the spinal epidural analgesia. Now come to the thromboprophylaxis. After the surgery, there is many complications like DVT. To prevent that, we can use the mechanical thromboprophylaxis by well-fitting compression stockings and or intermittent pneumatic compression until the discharge. Or we can give the pharmacological prophylaxis like LMWH once daily for 28 days after the surgery. When it comes to the electrolyte balance, the study shows that it should be preferred to use the hypotonic crystalloids rather than the isotonic crystalloids, which contain the high concentration of the sodium and cations and which can cause the volume overload and salt overload. Now come to the catheterization. Routine transurethral catheterization is recommended for 1 to 3 days after the colorectal surgery. And now come to the point of how many days you can use. That depends on the risk factors for the retention, like in male gender, or if we use epidural analgesia, or in case of the pelvic surgery, we use the catheter for 3 days. Otherwise, we use the transurethral catheters only for 1 day. Now, mobilization, prolonged immobilization is associated with a variety of adverse effects, so patients should mobilize therefore. Post-operative paralytic IVs. Multimodal approach to minimize the development of post-operative IVs are limited opioid administration through the use of multimodal analgesia and anesthesia techniques. And second, use of minimally invasive surgical techniques, and eliminate the routine placement of nasogastric tube and goal-directed fluid therapy. Now I am come to the next major surgical approach is the bariatric surgery and the guidelines for the IRAS protocol in bariatric surgery. First of all, alcohol and the smoking. Patients, as described previously, patients should stop smoking at least 4 weeks before the surgery, and if the patient has a history of the alcohol abuse, abstinence should be strictly adhered for at least 2 years. Now, preoperative weight loss should be recommended for the bariatric surgery. And preoperative fasting also, we can give clear liquid up to 2 hours and solid up to 6 hours prior to the induction of the anesthesia. Now, carbohydrate loading. Patients undergoing major abdominal elective surgery has been associated with the metabolic and clinical benefits by the oral carbohydrate conditioning. But if the patient suffered from the GERD-like disease, the oral carbohydrate loading may increase the risk of aspiration during the induction. Now come to the perioperative fluid management. Goal-directed fluid therapy should be added. Functional parameters like stroke volume variations, especially at the goal-directed fluid therapy. Intraoperative hypotension or excessive fluid overload should be avoided. Post-operative fluid infusions should be discontinued as soon as the practical with the preference given to the use of the enteral. Whenever we can give the fluid orally, we should stop the intravenous fluid administration. Now, laparoscopic surgery is recommended whenever the expertise is available, and the nasogastric tube, routine use of nasogastric tube is not recommended. Regarding the drainage system, insufficient evidence to recommend the routine use of abdominal drains also. And recommended the post-operative analgesia, again we should avoid the opioid and we should use the multimodal systemic medications and local anesthetic infiltration combined with the epidural analgesia. Regarding the thromboprophylaxis, We should involve the mechanical, like pneumatic compressions, and pharmacological, like use of the LMWH for 28 days. And dose and duration usually depends on the individuals and their body system. Post-operative nutrition, protein intake should be monitored in post-operative phase, and the iron, vitamin B12, and calcium supplementation is mandatory in bariatric surgery. And post-operative glycemic and the lipid control should be strict in the patients with the diabetes. Post-operative oxygenation. The bariatric surgery the patients undergoing bariatric surgery are usually obese. So the obese patient without obstructive sleep apnea syndrome should be supplemented with oxygen in semi-sitting position in the immediate post-operative period. And the uncomplicated patients who have the obstructive sleep apnea syndrome should receive the oxygen supplementation in semi-sitting position. Now we come to the non-invasive positive pressure ventilation. Prophylactic routine post-operative CPAP is not recommended in obese patients without diagnosed obstructive sleep apnea syndrome. CPAP is only given to the patients who have the BMI greater than 50 kg per meter square, who have the severe obstructive sleep apnea syndrome, who have oxygen saturation below 90%, even on oxygen supplementation. And the patients who have the obstructive hypoventilation syndrome, we can suggest the BiPAP therapy for them. Thank you.
Again, a nice presentation, but certain points, I think, for example, regarding pre-operative patient education, you have mentioned a few things, but you should certain points needs to be stressed, like such patients where you are planning for implementation of EDAS, you have to assess the patient in dedicated OPD sessions where you will be counseling the patient regarding the daily milestones you are aiming for. Like, for example, in day 1 you will be removing the catheter, you will start the oral feed from the first day onwards. Then in day 2 you'll be having this epidural catheter removed. Day 2, day 3 you will be planning to discharge the patient if you can tolerate orally, passing status, and having adequate analgesia with oral medication, and the patient is of course ambulatory. These goals should be properly explained to the patient, otherwise it may not be acceptable to the patient that your patient is undergoing a major surgery and you're planning to discharge the patient on the 3rd day. So everything can be done provided you are counseling the patient properly pre-operatively. And another point is, like, you should advise the patient to visit the particular ward where he is going to get admitted and have an orientation of the place. Admit the patient on the day of surgery. Don't admit the patient 2 or 3 days before the surgery. And especially for colorectal surgery, avoid pre-operative bowel preparation and go direct, especially for left-sided colonic lesion. You go for a simple enema on the day of surgery itself. Okay. And regarding if you are planning minimal invasive surgery, you have already mentioned, but it is not necessary that in all patients where you are following the ERAS protocol should be put to minimally invasive surgery. You can go for the same protocol can be utilized for open surgery as well. So in that cases, you have to decide upon what type of incision will help in quicker recovery of the patient. For example, right-sided operation, you try to go for a transverse incision like that. Again, regarding the surgical and anesthetic technique, that should be other surgical technique, anesthetic technique that should be followed to reduce the stress. Steroids, proper given per-operatively can help in reduction of the stress responses. Thermal control is important. Avoid hypothermia. Intraoperative fluid management you have mentioned very well. Goal-directed fluid therapy. How do you use that? How these goals are directed? It should be with the help of either invasive means like the intraarterial line, or by esophageal, esophageal USG Doppler probes that can be passed to note the stroke volume and others that you have mentioned already. Avoid fluids more than 1 to 2 liters during the intraoperative period. And carbohydrate load you have already mentioned. Rest, I think you have properly mentioned that.
In ERAS protocol, what is the timeline for discharge of this patient? Rubleka, what is the timeline? How is the discharge decided?
So according to the recovery, I'm
Yes.
not sure.
So discharge can be as early as within 24 hours.
As early as possible.
Yeah. And once you are trying to discharge the patient, that patient has to fulfill some criteria for discharge. Like patient should be ambulant. Patient should be ambulant, number one. Patient should be able to take oral feeds, and patient should be pain-free. If these three criteria are fulfilled, patient can be discharged home. Keeping in mind, but you see, the patient who are following the ERAS protocol, and you discharge the patient, some of these patients, varying between 5 to 10% of these patients, may require readmission. So you have to have a system where you can have a close liaison with the patient at home, and if need be, the patient should be readmitted. So that system should be there in the hospital. Our decision in our setup is it is difficult to communicate with the patient. It's difficult to get the readmitted. So in our part of this suggestion, we are not following ERAS protocol in most of the situations. Okay.
No,
I think it is a good presentation.
One more important, just a point passing remark. In case you are planning to discharge, as I said early on day 3, you should ensure that once the patient goes home, number one, there should be a support system for minor problems with patient that may crop up with the patient. And number two, there should be a method of communication. Like, for example, you should share a phone number or something by which the patient will feel that you are under the, still though he or she has been discharged from the hospital, he is still under the umbrella of the hospital care. Okay, so that is important also. Thank you very much. Nice presentation.
Okay. Any comment from anyone? Any comment from any other participant or any clarification?
Professor Saad, this is Dr. Acharya.
Yes, sir. Yes, sir. Good morning.
Yeah, I think she has covered it in a very extensive way, precisely also. But I want to press upon 2 points. One is you have to develop a team work for ERAS full implementation of ERAS protocol involving teachers who will explain these things, because for the surgeon it is not possible to cover all these things in his busy schedule. And possibly if you have the option in your center, you must include the counselors, psychiatric or counselors. And second thing I want to impress is that many of average Indian patients are quite sedentary in their lifestyles. So pre-operative, they should be encouraged to take exercise, particularly in chest operations and upper abdominal operations, so that their respiratory drive is bettered. So these 2 important points, I think, should be utilized before operation, pre-operative.
We give the spirometry to the patients who are undergone upper abdominal surgery or thoracic surgery.
Yeah. Actually, this whole ERAS protocol is a team-based work.
Yeah.
You need to have a home care nurse even. The nurse might visit the patient at home and then can give some basic care. It's a teamwork, starting from pre-op phase counseling to intra-op and then post-op. It's a integrated teamwork.
Yes, sir.
Okay. Thank you very much. I request other first-year DNB PGTs of other hospitals to join this group, and we'll involve all for presentation. Okay. So we continue with our program on for the time being Tuesday, Friday, and Saturday. Okay. Thank you. Thank you very much. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.